Thank you. Okay, so in 7 minutes, I'm supposed to talk about advanced reentry techniques. So these are my disclosures, nothing relevant to this talk. But I was going to talk about advanced reentry techniques, not about the devices. I think that's covered somewhere else, but how we use them in complex peripheral vascular disease, and particularly CLI patients. So there's advanced antegrade reentry, retrograde reentry, tibial reentry, suprapopliteal, and infrapopliteal reentry. This is our work in terms of tackling chronic total occlusions. The Saab trial published last year in February, looking at chronic total occlusions, and we came up with the CTOP classification. Very simple, straightforward, looking at the morphology of the proximal and the distal CTO caps for patients. And these are the distributions of a CTO cap morphology, about 142 CTOs. And if you notice, type 2, 3, and 4 are kind of the most common and most complex types of CTOs. So top of the screen is the common femoral artery, bottom of the screen is the foot of a patient. And in it, we tracked how often we crossed those lesions in an antegrade fashion, in a retrograde fashion, and what we describe as advanced techniques, meaning requiring antegrade and retrograde access. About 40% of the cases we required the antegrade and retrograde crossing. So to touch on one of those advanced crossing techniques, what we call the Readback technique, is utilization of the outback device in an antegrade fashion, and aiming for a retrograde balloon in a subadventitial plane. So the example that I'm showing right here is a type 3 CTO. The proximal CTO cap is convex, or distal CTO cap is convex from below. So no matter what we do, we're going to get deflected in antegrade fashion, retrograde fashion. And when we're trying to tackle the CTO, we know that we're going to be subintimal in antegrade fashion. We know we're going to be subintimal in retrograde fashion, as shown in the panel in the middle. There's a catheter in the subintimal plane from above, catheter in the subintimal plane from below. So what we'll end up doing is take an outback device, as shown in the example here. The outback is in antegrade fashion. The balloon is in a retrograde fashion, 4.0 by 120 millimeter balloon. And we basically aim with the needle toward that balloon and advance our wire from the outback device into the retrograde balloon, and thus use that balloon as a trapping mechanism and pulling it all the way down across that subintimal plane. And now you have a flossed artery from one subintimal plane to the next subintimal plane, and ultimately deliver therapy. Well, what about tibial CTOs? This is a complex tibial CTO. Perineal access was required because of a type 3 CTO. You get deflected in antegrade fashion, you get deflected in the retrograde fashion. And the comment that was made earlier today, we're utilizing intravascular ultrasound to help guide us in terms of crossing the CTO. And we can see that we were subintimal in a brief section of that CTO in the middle, but we were in the true lumen from above, true lumen from below. And ultimately, we were able to deliver therapy with orbital atherectomy, balloon angioplasty, and achieve adequate revascularization. The CART technique in the tibials, it is less favorable because there is a smaller room. There's a higher risk of complication for those patients. We tend to utilize smaller 0.14 balloons, antegrade 2.5 millimeter balloon, retrograde 2.0 balloon, overlap them by about 1 centimeter or so, and cross with from one subintimal plane to the next subintimal plane. Well, how about retrograde reentry? The first case would be PK. It's a perfect example. Usually they're very challenging. You have a convex proximal CTO cap that's not going to allow you to cross in an antegrade fashion, hence the approach in a retrograde fashion. So you try to tackle it in a retrograde fashion. This is an example kind of similar to the case that we saw this morning, maybe not as calcified. And what you see in the example here, the common femoral artery to the left of the screen, the SFA to the right of the screen, and you can see that the proximal CTO cap is convex. It's not going to allow me to penetrate that cap in an antegrade fashion. So the decision was made to approach it in a retrograde fashion. This is a claudication patient. We access the posterior tibial artery and cross the CTO from the popliteal all the way to the ostium of the SFA. And then we used the Wingman device. It's a device made by Reflow Medical. Has a needle about 4 millimeters throw, and under extravascular ultrasound guidance, something that we utilize quite frequently in our practice, we managed to penetrate the distal CTO cap into the common femoral artery and snare our wire and ultimately deliver therapy for this patient with atherectomy and balloon angioplasty for the patient. So in conclusion, advanced reentry techniques are important to incorporate in CTO crossing. Tibial CTOs are more challenging. They're smaller vessels with heavier calcifications. Reentry in plantar vessels is something that's still not clear or not easy to do. Reentry devices in tibial CTOs There are a few that are available, but they still need to be better. And retrograde reentry is an important tool, especially for CLI patients. Thank you.